All right, so scans again. So the routine is we draw blood, and then once we get positive tumor markers, then the doctor will proceed with a radiologic scan. And then once we find a tumor, we do a biopsy and then confirm the diagnosis. And we just discussed the, as far as if it's a bone marrow biopsy, for instance, we just discussed that last week as well, or was it 2 weeks ago? And this is an example of how we draw tissue sample, uh, whether it be on the liver, or breast, or any other tissue. Endoscopic procedures involve endoscopy, obviously, so that could be from your upper GI tract or up from the lower GI tract. Let's go now to treatment. If based on biopsy the cancer is not treatable or not curable, then our goal is either to reduce the tumor burden, meaning decrease its damage to the patient, or at least prevent its progression. We can do this by surgery, like debulking the size of the tumor, for instance. Um, let's say it's an inoperable brain tumor. If we can't if we can't remove the entire tumor, at least we can decrease its size so that at least the patient's symptoms will be less. For instance, the patient won't have as frequent seizures, for instance, or won't have as much pain or headaches, for instance, and also to prevent oncologic emergencies. Of course, our preference is, of course, to treat and cure the cancer, but in some cases it can't. In addition to debulking, for instance, there will be palliation as well. Palliation means palliative, which is symptomatic treatment. Now, don't confuse palliative treatment with end of life. Yes, palliative treatment is used in every end of life scenario. However, even if we're treating the patient's cancer, for instance, meaning the patient has a high likelihood of cure and survival, palliation is still part of it, because palliative is what it is, which is symptomatic treatment. Whether, regardless of the patient's prognosis, palliative treatment or palliation is always part of the treatment. Uh, Mostly it is toward pain management, but it doesn't have to be exclusively on pain management. We have three main treatment modalities. We have others like biologics. Now we use biologics or monoclonal antibodies to treat cancer. However, as we've discussed last week, these remain, the cost is prohibitive. So we stick with the three main approaches to treatment, which are surgery, chemotherapy, and radiation therapy. So let's begin. The oldest treatment is surgery. Surgery may not be the first option in some cases because, like I said, cancer cells have this ability to command the body to grow new blood vessels to feed it. We may have to wait until the tumor shrinks first before the doctor performs surgery. We can shrink the size of the tumor by giving chemotherapy and or radiation, whichever comes first, or maybe the doctor will do both at the same time before they do surgery. Or in some cases, surgery may be the only approach. So there's really no set sequence. Okay, so these are dealt with on a case-to-case basis. The doctor um, discusses the plan with the patient. this whole paragraph here tells you the different purposes of a surgery. For instance, if we say diagnostic surgery, we are referring to a biopsy. So we will perform surgery in order to take its tissue sample for diagnostic purposes. Other purposes of surgery, of course, is to cure the cancer. So we remove the entire tumor and finish it off with radiation and or chemo, because there's a possibility that we may have left some cancer cells during surgery. A few of them fell onto healthy tissue, and then that's what we call seed. Seed like a fruit seed. Okay, so some cancer cells may end up seeding, meaning we drop a few cancer cells. So some doctors may choose to finish off any of those cells by radiation or even chemotherapy. Some surgeries may also be done to, like I described earlier already, palliation, to meaning to debulk the mass, meaning reduce its size for symptom management purposes. It could also be to modify function, for instance, or to restore function rather. So let's say the patient loses their stomach or the small intestines, and then they'll end up with an ostomy, for instance. So those are examples of those types of surgeries, not really to um, to restore the original function, but now to modify the patient's normal physiology. Because the small intestine is now missing, then the patient will have to have an ostomy following surgery. It could also be temporary. Say most upper head and neck cancer patients, let's say involving the throat, will mean that there will be injury to the upper tract, resulting in an inability to chew and swallow. So the patient may require a peg tube for a short time, for instance. So that's another example of a surgery. So surgery here, as far as side effects, will really depend on what was removed or what was modified. Are you following so far? So as given here, example, a mastectomy, for instance. So after mastectomy, some patients may opt for reconstructive surgery. They'll get a new one, or they'll get a nipple recreated, for instance. So different types of surgeries, different purposes. As far as radiation therapy, there are two types here. We have external and we have internal radiation. In external radiation, you see the whiteboard, correct? You see my whiteboard, right?
Yes.
Okay. So this is the oncology office. This is the radiation source. This is the door. Okay, so patient comes into the treatment center. So this is the treatment room. This is in a oncologist's office. So patient stays here 1-2 hours and is exposed to radiation. They try to limit the radiation only to the minimum area. However, you do understand there will be collateral damage here. For instance, if we are radiating lung cancer, can we open the chest and then radiate only the tumor? No, right?
No.
So
No.
there will be collateral damage. So there will be injury to the chest area, the breast area, and the muscles underneath there. There will be also damage to the bone before we hit the tumor in the lung, and perhaps some lung tissue will be damaged here as well. But the precautions afterwards will differ if this was in brachytherapy. So this one is called teletherapy. Tele like telephone, teletherapy, or this is simply called external radiation. So the patient comes into the radiation treatment center, gets treatment for however long and how many times a week. They exit the door, they go home, they're fine. They are not radioactive because the radiation source is right here in this room. The patient didn't take it with them. So the patient received radiation while they are inside the treatment room. And again, they go home, they're fine. No precautions needed because they are not radioactive. They did not bring it with them. In brachytherapy, this involves now internal radiation. So the patient still goes to the treatment center. This time, the radiation source is not this. They will now implant a radioactive device or substance rather. So they'll put a radioactive substance in the patient. So perhaps, let's say it's a breast. So this is the area where the tumor was. Okay, so this is your patient. Looks like a dog, right? Okay, just imagine this is their head. Made it worse. Anyway, so this is the area where the tumor was. So they removed the mass, and then in its place, they put in radiation, sealed radiation. Okay, these are applicators. These are like sticks. Imagine the sticks they use for edible arrangements. Do you know what I'm talking about? So when you get a fruit from edible arrangements, they stick the fruit. Hello?
We know what you're talking about.
Yeah, so they put the radiation seeds at the tip of these applicators, and then they keep the applicators here. They tape it here so that it stays in place, and the patient goes home with it. Now, the patient is now radioactive because unlike here, wherein they didn't take it with them, this here remained at the treatment center. Now they went here. The doctor implanted the radiation source, and then this patient goes home and they are radioactive because they brought it with them. What was the question?
I have a question. So I know for radiation, like when you go in and you get the actual radiation treatment, part of the treatment for the patient, like aftercare, is to make sure that you lotion the area properly and take care of the skin that's being radiated. Does the same apply for the implant? Like, do you have to is it gonna affect the skin as much as like the teletherapy would?
No, very good question. Because the radiation here is inside the patient's body. It's usually in a cavity. Let's say here, this is a cavity, right? We created one after we removed the tumor. So there's a cavity left there, and that's where we put the radiation source. Now, it could be also inside the bladder. The doctor can put radiation seeds inside the bladder. You can put it inside the uterus. We can put it in the prostate. Any cavity, the doctor can put radiation seeds in there. The point is, there are two types of internal radiation. Radiation can be sealed or it can be unsealed. Usually, solid seeds like this are sealed sources, meaning they have a covering around the radiation substance, around the radioactive substance. In an unsealed, they have none, meaning this one, if it's sealed, if the source is sealed, the patient is radioactive because they brought it with them, it's inside them. However, A sealed radiation does not enter body fluids, meaning the patient's radioactive because they have the radiation source inside them, so therefore they remain a danger to people around them. However, anything wet coming out of the patient, let's say their urine, their feces, their saliva, are not radioactive because this is a sealed type of radiation, meaning it has no ability to enter the body fluids. It is only radioactive around the patient and also specifically around the tissues surrounding the radiation source.
Like
Do you
the
understand?
patient lives with the family have to stay away from them or like a certain distance from them?
Yes, we'll discuss the okay, let's do it now. So if it's sealed, the distance, the total, the total time, let's do time first, because there are three things you have to observe with radiation. We call it time, distance, and shielding. Shield meaning you have to put a barrier between you. The shield is usually lead. We use lead for usually here in teletherapy, because the technicians, let's say the radiology technician has to be around the patient, so he has to wear an apron, a lead apron, to protect himself from him or herself from the radiation. Okay, just like regular X-ray techs, so they wear one, right? Or you guys, you've been given one when you get your teeth X-rayed, for instance, at the dental office. So they give you a lead apron, right? So same thing. So this is our shielding. So this is for the caregiver and also for the patient. That way they don't get radiation in unnecessary areas. So only the target area, minimum necessary, will be radiated, and then we'll cover the patient with the lead apron here, for instance, and also perhaps on this area as well. So going back to internal radiation, because this is sealed, it does not enter body fluids. They do that for a reason, because the dose is higher here. Higher dose in sealed, so higher dose. So therefore, it's a higher dose. We cannot stay too close to the patient, so we're gonna have to stay only 3 feet. No, this is high dose, so it'll be 6 feet, sorry. So the patient and the visitor, or the caregivers, the nurses, for instance, has to be 6 feet away. And they can't stay for a total of 30 minutes. So they have to stay farther and stay shorter time. Are you with me so far? Because the dose is higher, although it doesn't enter body fluids. However, you have to maintain a safe distance, 6 feet, and no more than 30 minutes. This 30 minutes is total for the day. Okay. To protect yourself, of course, because you can't start an IV 6 feet away, right? You can't push a medication or take vital signs or listen to the heart and lung sounds 6 feet away. So we're gonna have to get close to the patient. So make sure the total time you spend for the patient is no more than 30 minutes. Clear? And whenever you're within 6 feet, you have to wear this lead apron here for your protection. Now, to determine how much radiation you've been exposed to, we have something called a dosimeter film. Okay, it's a badge we wear, and this thing changes color. The more radiation you're exposed to, it will start changing color. For unsealed, these are usually either ingested in a capsule or liquid, or injected. So PO or IV. Or it could be also intravesical, meaning inside the bladder. It could be intraventricular, meaning inside the ventricles of your brain, um, inside your bone. Regardless, it's unsealed, so therefore it enters body fluids now. Because it's not sealed. So whatever wet comes out of the patient, again, urine, feces, seminal fluids, semen, vaginal secretions, tears, saliva, mucus are all radioactive, except maybe sweat. Never really read sweat in any textbook, so sweat should be fine. Anyway, so we have a unsealed radiation. It enters body fluids. However, the dose is lower, and in some cases they don't have to retrieve this. I mean, you swallowed it. It was injected in you, so the body naturally gets rid of it. Phagocytosis, for instance. Plus, they don't stay radioactive forever, so the radioactivity will eventually wear off. However, it is still radiation, so now you can stay 3 feet away, so a little closer, and then you can also go 1 hour total now. All right, so these are our precautions. Let me summarize. If it's external radiation right here, the patient receives radiation therapy. They are not radioactive because the radiation source is right here. So they go home, they are harmless. When we use brachytherapy or near close, that's what brachy means. There are two types. We have sealed and unsealed. If it's a sealed radiation source, the patient carries the radioactive material with them. However, they are sealed, so no body fluid involvement. The radioactivity does not affect body fluids, only the tissues around the cavity where it is implanted. As far as the question earlier, will it affect the skin? No, because this is inside. This one here affects the skin because the skin is radiated. So you stay, this is a higher dose, so you stay farther and you spend less time with the patient. For unsealed, these have no covering, so they enter body fluids. So anything wet coming out of the patient is radioactive. So you handle those stuff with separately. You can, however, stay closer, 3 feet away, and then you can stay double the time longer. But in either case, if you're really close, like you're really all over the patient, you have to wear a lead apron. Again, to monitor your exposure, you have to wear a film badge, dosimeter film badge. This thing does not offer any protection. This is just for monitoring purposes so that you're aware if you've been exposed to too much radiation during the shift. Any question?
Oh, Professor, I got
Yes,
two questions.
Professor, I have a question. Okay, if a nurse is pregnant, does that nurse can take care of that patient?
No, very good question. No pregnant women, that includes nurses, and no children. So that will also include visitors. So no pregnant nurses or no pregnant visitors, and no children visitors. What's your question, Israel?
Why would we choose the Tela over the Brachy treatment?
That's not our decision. That's according to the radiation oncologist.
Okay. And my second question was like how come like all of the body fluids would probably be radioactive, possibly besides the sweat?
I really don't know. In fact, with any other infectious disease, except maybe fungus, because you come in contact with the skin, which is where your sweat is. That would probably be the only disease that is transmitted through sweat. But everything else, hardly. Like HIV is not found in sweat, right?
Yeah.
There's some in the saliva, but that's about it. I mean, we don't really find many infectious organisms in sweat, except maybe fungus. But otherwise, any other bloodborne infection or like HIV, hepatitis, it's in all others except sweat. I mean, I haven't even read hepatitis A being transmitted in sweat either. I don't know why.
Okay.
Yeah.
I also have two questions.
I
Yeah,
have the
because it's not a normal portal of exit, if that makes sense.
Yeah.
Because our normal portals of exit is the GI tract, respiratory tract, urinary tract. There's really no skin. The skin isn't a portal of exit unless you have a wound. Yeah, that's a wound is a portal of exit, but sweat glands, they're not portals of exit.
Okay, gotcha.
Yeah. Yes. Another question?
Um, this is yeah, I have two questions. First one, let's say a patient has the sealed one. Are you talking about so if there is some drainage from the insertion site, that also fluid also doesn't is not radioactive?
No, it's not. It doesn't. Again, it has no capacity to enter the enter body fluids, because how radiation works is it's absorbed by the cell. So whether it's external radiation or internal radiation, the how radiation works is it destroys the cell. So they may not be destroyed today, but they absorb the radiation, and the cancer cells as well as the normal cells around them get sick, okay, because the exposure to the strong radiation. So they get sick and then they die. They don't die today. Some of them may die today, but most of them die later, like tomorrow, the next day. So they continue to die later. That's how radiation works. So they are harmful to cells. They cause cell death. And it's just a matter of when these cells will die, but they will eventually die. That's how radiation works.
My second question is that the timing limit, the 30 minutes or 1 hour, is that per patient per day, or is that like per day? So if you work on the oncology floor, do you have to limit all your patient contact time to 30 or 1 hour per shift?
Yes, that's all the limit you have, because anything longer than that, it's already harmful to you. So that's why they don't give you multiple radiation assignments. You're limited to one radiation patient, because if you have multiple, then that will add up. Oh, 15 minutes here, 45 minutes there. You understand? That very good question. Yeah, there will
I
be
just
no
didn't know the
multiple.
nurse to patient ratio is that low.
I mean, I mean, it's not going to be. Of course, they take these into account already. The oncology unit already knows that, so they will staff them appropriately, because that's against OSHA. You know, they'll be violating the law. Any other question? All right, let's go back here. Okay, so that's radiation therapy. Please read these on your own. These are the nursing responsibilities. I'm not really going to test you on the second and third columns. It's really on this column right here, patient education column here. where the questions will come from, because these are going to cover what you teach the patient, what your responsibilities are yourself, okay, and more importantly, what are possible side effects of the radiation treatment. And as stated here in this highlighted section here, it's really going to depend on which area is radiated. So this is obviously in external radiation. So for the external radiation, the side effects usually are local. It's around the treatment area. Whereas if it's unsealed radiation, because you swallowed it or it was injected to you, you may have some systemic effects. I mean, systemic side effects. But as far as external radiation, no. The only one that's an exception is fatigue. Fatigue is probably the only systemic side effect associated with external radiation. There's some explanation for it, say anemia, because it does cause, let's say it hits the bone marrow, it does cause pancytopenia. However, there is a fatigue that can't be explained either. And here's your responsibilities for internal radiation. I described it already. Make sure you really isolate, meaning can they use the same toilet as everybody else at home?
No,
No.
Professor.
No.
All right. But if let's say you have only one toilet, then you have to clean after they use it. Okay, making sure there are no urine spills. If there's a spill, you have to clean it up. Okay, make sure it's really clean. We use bleach. You can use bleach. That will be enough to remove radioactivity. As far as clothes, also, they can't wash them together with other family members' clothes. Utensils, the same thing. So pretty much anything that touches their body fluids can't be used. As far as washing machines, that's fine. You can just wash their clothes separately and then at least run the washer empty one full cycle before you use it with the clothes of the rest of the family, just to make sure the radioactivity was cleared. All right, so this is what I was discussing earlier, the seeds. Here's an example in the prostate. They leave these alone. I mean, they're not going to retrieve them. I mean, it's impossible to take them back out. So they just leave the seeds there. Like I said, the body will eat them up. Your phagocytes, your macrophages will just eat and get rid of them later, eventually. Here's the fatigue I mentioned, and then most of them again are site specific, especially if we're dealing with sealed or external radiation. So the surrounding area will have some damage or side effects. Here's chemotherapy now. Definitely chemotherapy side effects will be systemic, unlike radiation, wherein especially external, it's more localized, except fatigue. The questions on the exam will not be on the chemo drugs. Okay, they will be on the side effects of the chemo drugs. Here are your side effects, table 13.6. Again, it's not going to be on the drug itself. It's going to be on the side effects. More importantly, I'm not testing everything. Here are the ones you study. Look for management of alopecia, hair loss. Are you taking notes?
Yes.
Yes,
Okay.
Professor.
Next is Milo suppression, that is bone marrow suppression. Now, I don't have to break this down. Milo suppression means you have anemia, thrombocytopenia, and neutropenia. So all three. So make sure you're aware of nursing care of these three. You can find them under the chapter where you did your presentation last semester under bleeding and clotting disorders. Remember your project last semester? that chapter where you had anemia, thrombocytopenia, and neutropenia. Nursing care, okay? So where are we? Alopecia, Milo suppression, and then nausea vomiting is a big thing. Why is it a big deal? Well, if this patient stops eating because they're nauseous, they're vomiting, what will happen to their health?
They cannot make their nutrition.
They cannot, right? Exactly. They cannot eat. Are they going to be healthy enough to continue radiation and chemo? No. They will die if they continue and they're malnourished, they have anemia, they have thrombocytopenia, or if they develop an infection because of the neutropenia. We have to stop the treatment, or else it will kill them. Oral mucositis. This is also important. These are large ulcers that form in the mouth, in the tongue, in the cheeks, in the gums, in their throat, all the way down to the rectum. The reason for this is basically what you see in this table are effects of cancer treatment. Cancer treatment definitely kills cancer, correct? So that means how they work is, I don't know why this is, okay, so these are cancers.
He should text
Cancer.
me again. Tell her
Hello?
go.
What? Are you talking to me? Hello? Okay, whatever that was. Mucositis, these are large ulcers. They form because your cancer treatment will kill all rapidly dividing cells, and it just so happens that your GI tract from your mouth down to your rectum are made of rapidly dividing cells. So all of them will be killed, resulting in these large ulcers. So here's the management down here under table 13.7. So focus on alopecia, nausea vomiting, bone marrow suppression. But again, the bone marrow suppression results in anemia, thrombocytopenia, and neutropenia, which is found in other chapters, which we've covered in the past. So this is referring to nursing care. How do you care for these patients having bone marrow suppression? And then as far as nausea vomiting, there are several drugs used to treat nausea vomiting, because they will have three types of nausea vomiting here. One is acute, meaning they're nauseous right now. These patients will also have anticipatory nausea vomiting, meaning they haven't even received the treatment yet. Just thinking about it, they already become nauseous. And third, there's also delayed nausea vomiting, meaning even after the treatment, after chemotherapy, they can be nauseous up to a week after the treatment. Look at management for oral mucositis, meaning mouth care, because if you have these large ulcers in your mouth, are you going to eat? Are you going to swallow? No, these are very painful ulcers. So make sure there's enough mouth care, and then pain management. For usually we use viscous lidocaine. It's listed right here, viscous lidocaine rinse. And yeah, we covered alopecia, meaning this will be your education, especially with women. That's a big deal when women lose their hair. How do you protect? Plus the hairless scalp is really prone to injury, so protect that from the sun. Maybe put sunscreen on a hairless scalp. So we did alopecia, bone marrow suppression, you're in charge, nausea vomiting, look for the drug therapy, and then mucositis. We already covered the bone marrow transplant, so I'm not repeating that. Here is pain management. You had a different acronym last semester. Here's another acronym for cancer. This is pain assessment. Old CARTS, onset, location, duration, character, aggravating or relieving factors, radiation, timing, and severity. Oh, that was it. Okay, lastly, there are 3 medications to be used for your pancytopenia. I'll list them down here. Some of them are found in your textbook under hematologic disorders. Some may not be. So for anemia, we use epoetin. This is Epogen or Procrit. These are subcutaneous injections. For thrombocytopenia, we use Oprelvicin. This is called Numega. For neutropenia, we use filgrastim or pegfilgrastim. This is, I think, Neulasta. No, this is Neulasta. This is Neupogen. All right. So this drug will increase red blood cell production. Most common side effect here, of course, if we get too much, then you'll have too much red blood cells. That could lead to blood clot formation, increase blood pressure, and then you can have an MI, stroke, a PE. Thrombocytopenia, this thing typically increases blood volume, thickens the blood because it will increase platelets, so you may have fluid overload with this thing. Neutropenia, because this forces your marrow to produce white blood cells, this may cause bone pain, among other side effects. So use your drug book. So if you can't find these 3 drugs in your textbook, use your drug book. These are commonly tested drugs on the NCLEX because you'll be taking care of patients with receiving chemotherapy. Again, the questions will not be about the chemo drug. It will be care of a patient receiving chemo. So you are managing these common signs and symptoms, namely nausea, vomiting, mucositis, bone marrow suppression, which you have anemia, thrombocytopenia, and neutropenia, and then the hair loss. And that concludes cancer. Any questions? Violent reactions?